Right, Ritin will be speaking on just a second. Up, I think this talk is called Update on Diagnosis of Corneal Ectasia. Over to you, Dr. Ritin.
Hi, thanks, Dr. Jia, for the kind introduction. I'll be talking about diagnostics in keratoconus, and actually, I'll be talking on multiple things within keratoconus. Uh, just to, a sort of a classification that clinical classification that I'm using in my own clinic, and what are the diagnostic tests that we run based on this classification, and what is the treatment protocol. So that's what I'll be trying to cover in this. I have no financial disclosures to make, and the views in this presentation are based on my education, my training, my experience with my patients, and these are outcomes that I've got in my hands. Some of these are new techniques, so I advise a little bit of discretion. I think history taking itself is a very important diagnostic tool. Knowing the history of allergy and eye rubbing, history of any previous laser refractive surgery, any history of pregnancy, so many systemic diseases, things like Down syndrome, these can be very important. We know that there are some risk factors where we do see keratoconus being more aggressive, more progressive, like age, younger age, female gender, high refractive error laser refractive surgery with thin pre-op pachymetries as well as suspicious corneas. So the go-to is corneal tomography. What the machine that I use is a pentacam at all my centers. And what is it that we look at on a pentacam? The most commonly seen scan is the refractive format scan. We can see in this case there's inferior steepening as well as focal thinning. The anterior and posterior elevations are increased. But looking at this map, once that you've diagnosed ectasia, then the things that I really want to note down is the K1 and K2 values, what is the minimum pachymetry, and what's the Kmax of the front. Once that I actually have established ectasia, for me, Bellin-Ambrosio enhanced ectasia is not very useful anymore, especially in serial scans. This is probably not a great tool to be looking at for keratoconus progression and follow-up. The Corvus ST and the ORA, they show a lot of promise in corneal rigidity, but looking at all the papers that are out there, it doesn't seem like they will have any good role in established cases of ectasia in actually determining whether these patients are progressing or not. The sensitivity as well as the specificity of progression on any of these corneal rigidity tools is still, I think the evidence is still quite weak so far. So going further, this is a discussion, this is a conversation that I have with all my keratoconus patients, that now that you've been diagnosed with keratoconus, there are two lines of treatment starting from today. One line of treatment is that we need to stop your progression, and the second line of treatment is that we need to give you good vision. Stopping progression, we've already discussed the possible risk factors. For improving vision, we have a host of things, such as glasses, rigid lenses, topoguided PRK with cross-linking, lenticular insertion techniques, impacts, and then keratoplasties. So just talking about halting progression, we have to remember that keratoconus is a non-progressive, then progressive, and then again non-progressive disease. The child is born with a normal cornea, with normal tomography, normal topography. At a certain point of time in his or her life, he or she will progress to have corneal ectasia, and then this corneal ectasia is going to stabilize at a particular age or at a particular time in their life. And this is the natural progression of the disease. This is the natural course of the disease that every patient will have over time. This classification that I'm talking about is based on minimum pachymetry, where we've looked at patients with minimum pachymetry of more than 500, more than 450, those between 400 to 450, those between 350 to 450, and less than 350. So these patients who have more than 500 microns of pachymetry, they usually have good vision or good acceptance of glasses. They're usually incidentally diagnosed. They're probably looking at laser refractive surgery. Uh, they usually have Kmax, which are in the late 40s, maybe in the early 50s. You can get good results with a good refraction and with glasses. So my diagnostic point for a refraction in these cases is don't try to completely treat the cylinder. Don't try to completely treat the myopia. Keep them slightly undercorrected. Patients tend to do much better with undercorrection as compared to full correction. If we are trying to do a full correction to your objective refraction, these patients will have a lot of strain and a lot of asthenopic symptoms. Pentacam needs to be repeated every 6 months, maybe once or twice, and then annually for a couple of years. And we don't really need to follow these patients up beyond a couple of years once that we know that keratoconus has been stable. These patients are usually very good candidates for ICLs if they're accepting glasses well. Patients where pachymetry is between 450 to 500, they complain of a lot of distortion. They really struggle in getting good glasses from an optometrist. Refraction in these cases can be quite hit and trial. We still continue to do repeat pentacam in 6 months gaps. A rigid lens trial for me is the most important diagnostic tool. It will help me in finding out whether this patient can actually have good vision or not. If the patient accepts rigid lenses, I think they can have excellent vision with those. These patients make very good candidates for topoguided PRK with cross-linking, like Athens protocol, or with Intax. This is a patient of topoguided cross-linking that we did, and this is 2 years outcome, and you can see that patients, the anterior surface of the cornea has become a lot more regular. 300 to 350 to 450 microns of pachymetry. These are cases where vision is significantly poor. They have significant distortion of light, and refraction is very unlikely. We continue to do pentacams just to rule out whether their vision is, whether their keratoconus is progressing. Rigid lenses are most helpful in these cases because no refraction would really help these kind of cases. Usually, trial of hypoosmolar C3R can help stop progression in cases below 400 microns. I'd like to share a case of stromalenticular insertion that we've done for one of these cases. This is a femto-cut stromal lenticule that we inserted within a stromal pocket within the keratoconic eye. And if you look at the pre and post-operative of these patients, we got about 10 diopters of flattening in the center, and we now have pachymetry of around 550 or so. We're considering doing a Athens, like a topoguided PRK with cross-linking sometime in the future once the things kind of settle down. Patients with less than 350 microns of pachy, these have poor vision and they have really poor vision. It's hard to fit a rigid contact lens unless you're doing a mini scleral lens. Keratoplasty is probably their best option. This is a case of femto-assisted mushroom cut keratoplasty that did quite well. Thank you.